Hello and good morning. Happy American Heart Association 2025 Day. My name is Chris Suprin. I am a long-term American Heart Association instructor, and with the new guidelines dropping today, I wanted to do a quick video on what they look like and what it means to providers both in and out of hospital environments. Again, my name is Chris Suprin. I have been an advanced life support provider in the field since 1993. So I started with the 1990 American Heart Association standards as a lifeguard. I am currently training faculty for the September 11th Foundation. We are always accepting applications for new instructors and looking to expand our reach. And in the past year, have taught several hundred students CPR, ACLS, PALS, pretty much the gamut. Regularly, when new guidelines drop, I see providers both in and out of hospital environments worry about how the new standards are going to change their care on a day-to-day basis. In some cases, like 2000, we have tsunami-like changes. When I look at the changes just first read, 2025 looks like it's going to be much more of a trickle of information and not the major changes that some people fear. As always, as we jump right in, keep in mind that American Heart Association, when they drop guidelines, always divides information based on levels of evidence. We know that if we put two docs and two paramedics and two emergency nurses around a table, they may have an expert consensus opinion, but that opinion is not nearly as strong as double-blind, placebo-controlled studies. And we see those levels of evidence on the right. On the left, we have classes of recommendation. Level 1 recommendations are always a good idea. Things like epinephrine every 3 to 5 minutes or using waveform capnography. As you go down that list to class 2 and 2B recommendations or class 3, which are divided into minor or harmful recommendations, these are based on increasing risk, increasing side effects, things that become more dangerous for the patient, or don't have the level of evidence to support a class 1 recommendation. So, jumping right into adult basic life support, adult cardiac arrest. The first bulleted point from the American Heart Association is that we should be performing resuscitation where the patient is found as long as high quality CPR can be administered safely and effectively. I feel like this is not necessarily a new standard, but a new point of emphasis. For years, EMS has tried to work patients where we found them as opposed to moving them and delaying those initial CPR compressions, which were in some cases life-saving. The other point that is emphasized heavily, but really goes back to science from the 1990s, is if we are the only provider, we should be activating the emergency response system early and first prior to starting CPR. Where we're headed there, it appears, is we want to get that AED on the way with public access to defibrillation available across the country. It is imperative that we get an AED on scene as quickly as possible to deal with any ventricular fibrillation situations that exist. We also know that in 2005, there was an emphasis for the lay person to focus on compressions only and no airway. It is reasonable, though, for healthcare professionals to continue chest compressions and ventilations for all adult patients in cardiac arrest, whether their cause is primary cardiac or non-cardiac. Continuing, American Heart Association notes that the routine use of mechanical CPR devices is not recommended for adults in cardiac arrest. For those of us in EMS who have used these devices, we know that they can be force multipliers, but there is also a timing issue of when the device is placed. Are we getting good CPR initially, or are we actually delaying that good CPR? This is also not a change. This is what we've been doing by standard for a long time. Additionally, we're going to continue to breathe 1 breath every 6 seconds or 10 breaths per minute for the adult patient. Obese patients are going to get the exact same techniques as we have used on any other patient in the adult community for multiple cycles of AHA releases. The foreign body airway obstruction standard is predominantly not changing. We're still going to do 5 back blows followed by 5 abdominal thrusts until the patient either expels the object or the patient becomes unresponsive. And then last but not least, during adult cardiac arrest, we should be using PPE while performing CPR. Again, this is something that goes back to your OSHA 1910 standards. If you're not using PPE in this day and age, I'm not sure why not. So now that we've talked about BLS and CPR, let's talk about adult advanced life support. American Heart Association is recommending a rapid assessment of clinical stability to direct ALS treatment. The point here being, we know that poor organ perfusion ends up showing up as instability, and it's something we need to recognize early in a resuscitative effort so that we can be able to better treat these patients. Another recommendation that is a little bit of a change is higher first shock energy settings for AFib and AFlutter when we're cardioverting those patients. We know that higher energy settings are preferable to lower energy settings when we're going to perform these procedures, and that is a change from the old 100 joule standard. There is also an emphasis on termination of resuscitation based on EMS scope of practice. Are you a BLS crew? Are you ALS? Is there a role for a universal termination of resuscitation rule? As part of that, American Heart continues to say that end-tidal carbon dioxide should not be used as your only endpoint to guide the stoppage of any kind of resuscitative effort. Now, another point that I know is going to make some physicians in Florida and Oklahoma unhappy, but American Heart Association says that the usefulness of vector change and double sequential defibrillation has not been established as therapies for shock refractory VFib. They do encourage continued trial and study, but for right now, they are not recommending those measures be performed. Finally, there has been some conjecture that a CPR resuscitation should include raising the head of the bed. There are a number of reasons for that. Currently, this is discouraged by American Heart Association outside of clinical trials with appropriate subject protections. Continuing with adult advanced life support, there's been a move, obviously, away from using drug dosages down ET tubes, and that has been acceptable for a long time as a backup. American Heart Association says, these are outdated and extraordinary procedures. We've got modern equivalents with better efficacy, so we need to remove those completely, and they have done that. Another move they have made, though, is to add point-of-care ultrasound. We know that one of the H's and T's for cardiac arrest causes is tension pneumothoraces. We can locate that with an experienced provider with a point-of-care ultrasound. There is also some conjecture that we might be able to better determine whether a patient is in what we'd call a stone heart asystole, or if there's still some muscle activity that would support life. The point is, point-of-care ultrasound by experienced providers during cardiac arrest may be considered to diagnose reversible causes. This is obviously a positive step forward and something in the skill area where we're all going to have to add to our toolbox of skills that we can use for resuscitation. American Heart also notes that polymorphic VTAC is considered unstable in all events. Therefore, we're going to treat it like unstable VTAC and immediately move to defibrillation. We know that we get worse outcomes when we delay that shock therapy. Another topic where we're kind of coming full circle is we're going to use intravenous access as our first line choice for drug dosing. IO is still a reasonable alternative if IV access is not feasible or it's delayed. That will be interesting to see how the EMS community adopts that. Given the number of IO needles that have been dropped, I would say in the past 10 to 20 years, based on the recommendation that IO access is a fast, reasonable way to run fluid and drugs quickly. Finally, there is a recognition that arrhythmia may be a sign and symptom, or it might be the primary cause of a clinical instability. So we're going to evaluate the proximal cause of these arrhythmia, and that will direct our ability to use the guidelines most effectively. And that is a new statement from American Heart that recognizes the arrhythmia may be the problem, or it may be a sign of something else. When you look at the algorithm for sudden cardiac arrest events, you will notice this looks exceptionally similar to what you saw in 2020. Again, drug dosages themselves are not changing. We are still giving epinephrine every 3 to 5 minutes, the 1 milligram of 1 to 10,000 dose. We are still choosing between amiodarone or lidocaine at the doses we're all familiar with, and the H's and T's have not changed. So again, if the new standards dropping are giving you palpitations yourself, or you're otherwise worried about them, understand that this is a great example of things aren't changing as much as they may seem. There are some clinical ideas we need to adopt and consider, but by and large, things are more similar than they're not. So don't be afraid of the new standards and be comfortable jumping right in. So let's move to the pediatric side. I always like to ask groups of people, what are the top 10 causes of pediatric cardiac arrest? And we know that the answer is respiratory conditions. Normally in class, I will hear respiratory, and then I'll say, don't forget choking, don't forget drowning, don't forget too much CO2, don't forget not enough O2. The point being, pediatric cardiac arrest is consistently almost always respiratory driven. Not completely, but very heavily. So it is important for us to be comfortable responding with good airway and breathing interventions early. This includes at the layperson level, providing rescue breaths if you're able and willing. The rate for respiratory resuscitation is 20 to 30 breaths per minute for infants and children. And again, we know that children are respiratory driven, so we need to get those breaths on board and airway support as quickly as possible. For children who are choking, again, we're going to alternate 5 back blows with 5 chest thrusts. We are not doing abdominal thrusts in infants, but we want to relieve that choking object. And we're going to continue that so that we can remove the object and support their respirations otherwise. It is critical in pediatric basic life support that we recognize cardiac arrest if we're going to improve outcomes. We still need to activate the emergency response system as well as do high quality CPR with good ventilatory effort as early as possible. High quality CPR is the foundation of resuscitation for both adults and children, but this is emphasized in the pediatric population. In addition, American Heart recognizes that we can use either the one hand or 2 thumb encircling technique. For those rescuers who cannot physically encircle the chest, it is recommended that we compress the chest with the heel of one hand. The use of 2 fingers along the sternum was eliminated because it's just not nearly as effective as using 2 thumbs or one hand to achieve proper depth. Remember also, we can use an AED on children. We should use pediatric pads when and where available. And finally, we need to defibrillate children in VFib or pulseless VTAC as early as possible. Moving into pediatric advanced life support, high quality CPR matters, and it is a critical component of providing good resuscitative care to our pediatric population. So making sure we've got full chest recoil, we are getting to adequate depth, we are compressing at an appropriate rate. These are all critical. Similarly, if we have a non-shockable rhythm, we should be getting epinephrine on board as early as possible. 10 micrograms per kilogram of 1 to 10,000 dose epinephrine. And again, for shockable rhythms, we should also be getting defibrillation on board as quickly as possible. End tidal CO2 is a great indicator, or it can be an indicator of CPR quality, but the use of specific end tidal CO2 numbers to discontinue termination is not advised. As we finish out initial read-through of pediatric ALS, keep in mind it is important to prevent hyperthermia in post-cardiac arrest patients. At the pediatric level, this is a point of emphasis. In addition, we want to maintain blood pressures greater than the 10th percentile for age and sex. So that's something else to keep in mind as well. As we continue post-cardiac arrest care, continue considering options to make sure we're maintaining neural pathways, that we are getting either MRI or some sort of imaging to have a baseline for post-insult care. And we do this at multiple time points. We may start physical therapy options so that we can evaluate a patient's ability to function as fully as possible post-insult. And keep in mind that these are not single event issues, but things that may be ongoing. And that is a quick and dirty first read of the American Heart Association 2025 guidelines that dropped today. If this content was at all useful for you, please hit the like and subscribe button. If you have other ideas on content, please email me at admin@neverforget911.org. This is a new channel that is going to be focused on bringing critical care topics as well as continuing education to the both pre-hospital and in-hospital communities on a number of topics. But today I wanted to hit the new AHA standards so that you are not afraid of what might be. The boogeyman that comes at Halloween is not coming today. We have a lot of new guidelines and points of emphasis that should sound very familiar, and that should not be scary at all, but make you feel good about the care you're providing. Thanks for listening, and again, please hit the like and subscribe.